Good afternoon, everyone, and welcome to today's PHO webinar, Antibiotic-Resistant Organisms, Time for a Rewind. My name is Casey Gambetta. I'm a team leader for the Infection Prevention and Control team at Public Health Ontario, and I'm thrilled to be moderating today's session. Alongside me is my co-moderator and colleague, Lori Schatzler, who is an IPAC specialist at Public Health Ontario. I'll now hand it over to Lori for the land acknowledgement.
Thank you, Casey. I kindly acknowledge the land on which I live and work, which is on the traditional territory of the Atikamekw Anishinaabeg, descendants of the Ojibwe, Algonquin, and Odawa nations, and one of the 21 First Nations communities in the Robinson-Huron Treaty Territory that extends along the north shore of Lake Huron and Georgian Bay in northeastern Ontario. I also acknowledge all First Nations, Inuit, and Métis peoples, past and present, whose lives have been impacted by the effects of colonization. As we pause to recognize National Infection Control Week 2024, the theme Prevent with Intent, I encourage each of us to be curious learners, intentional listeners, and ongoing mentors, where we can positively contribute to reconciliation and the health and well-being for all. And now I'll pass it back to Casey.
Okay, it's now my pleasure to introduce my colleagues and the speaker for today's presentation, or the speakers for today's presentation, Catherine Kerr and Eva Skiba. So Catherine Kerr holds a Master of Science degree in microbiology and immunology from Western University and has been an infection prevention and control specialist at Public Health Ontario since 2022. With over a decade of experience in the field, Catherine has maintained continuous certification in infection prevention and control since 2012. Before joining PHO, she worked as an IPAC professional in both community and large academic hospitals. Currently, Catherine serves as a co-subject matter lead for antimicrobial-resistant organisms at PHO. Joining her is Eva Skiba. Eva has been an infection control specialist at Public Health Ontario since 2009. She holds a Bachelor of Science in Nursing, a gerontology nursing certificate, and a certified infection control designation. As an active member of IPAC Canada, Eva previously served as the president of the Greater Toronto Area chapter. She began her career in long-term care in the 1990s, gaining extensive experience in infection prevention and control and in director of care roles. Prior to her time at PHO, Eva worked in infection prevention and control at Credit Valley Hospital. She has also presented at national conferences and various provincial and local events. In addition to our two speakers today, I would like to say a quick thank you to Peg Ashley and Melissa Miller for their diligent support in bringing this session to you today. I'm now going to pass things over to our first speaker, Catherine, to start the presentation. Thank you, Catherine.
Thank you, Casey and Lori, for the introduction, and thank you all for being here with us today, and happy Infection Prevention and Control Week 2024. So today we'll have a booster on antibiotic-resistant organisms, also known as AROs, as well as the best practices for managing patients, residents, and clients with AROs. We'll also have a discussion of the resources to support ARO best practices, and we'll close with a question and answer period. So by the end of the session today, we should all be able to have a general understanding of the different AROs, including the risk factors, screening, and case management for the different antibiotic-resistant organisms. Be aware of the various PHO resources available for AROs, and how to understand how these resources can be used. We have many resources that can help in implementing a new ARO screening program or expanding an existing ARO screening program. So for example, if you're setting already screens for MRSA and VRE, we do have helpful tools for you to expand if you wanted to add CPE. And finally, we hope that everyone will be able to apply their knowledge of AROs within your own healthcare settings. So as mentioned, we'll start with a booster on antibiotic-resistant organisms. So what are they? AROs are germs that have become resistant to the action of typically several classes of antimicrobial agents, and the organism is of special clinical or epidemiological significance. The AROs that we will be discussing today include MRSA, or methicillin-resistant Staphylococcus aureus, Vancomycin-resistant enterococci, or VRE, extended spectrum beta-lactamase producers, or ESBL, Carbapenemase-producing Enterobacteriaceae, or CPE, as well as Candida auris, or C. auris. So each of these AROs are capable of causing both colonizations and infections. And colonization is when a microbe, it's in your body or living on your skin and it's growing, but it doesn't invade tissue or cause any cellular injury. So when someone is colonized with an ARO, they show no signs or symptoms of illness. Infection is similar to colonization in that a microbe is present in your body or on your skin and it's growing. But in this case, infections happen when the microbe is able to invade tissues and cause cellular injury. So when someone has an infection with an ARO, they will have symptoms related to the site of infection. So if someone has a VRE UTI, they'll experience symptoms of a UTI, such as flank pain or increased frequency or urgency. Okay, so we know what AROs are. Why are we concerned about them? Because AROs are resistant to the antimicrobials that are used to commonly treat them. So for example, in vancomycin-resistant enterococci, enterococcal infections are often treated with vancomycin. And so this leads to a delay in the correct treatment with the correct antibiotic. Patients who have an ARO also experience increased length of hospitalization compared to patients who don't have an ARO. They're a common cause of healthcare-associated infections, and individuals with an ARO experience higher rates of morbidity and mortality. And then finally, concerningly, that resistance to antibiotics is developing faster than new antibiotic discovery. So each of the AROs that we will be discussing today have common risk factors, and it's important to screen patients and residents who have these risk factors for AROs so that they can be identified early and managed appropriately. And we'll talk a little bit more about screening for AROs in more detail a little later in the presentation. But the common risk factors that have been identified among individuals who are at increased risk for acquiring an ARO include exposure to a healthcare setting, and then, of course, the longer the length of hospitalization, the higher the risk of acquiring an ARO is. Requiring invasive medical procedures or devices, or having intense nursing care needs, and then the severity of other comorbidities also put someone at increased risk for acquiring an ARO. Additionally, being treated with antibiotics or antifungals is also a common risk factor for acquiring AROs. And then finally, having contact with a case, such as sharing a room or being on a unit during an uncontrolled outbreak, as well as having a prior history of having an ARO, also put individuals at increased risk for ARO acquisition. So with that said, we'll talk a little bit just about the different AROs that we are concerned with in healthcare. So the first ARO that I will be talking about is methicillin-resistant Staphylococcus aureus, or MRSA. So MRSA, as I mentioned, stands for methicillin-resistant Staphylococcus aureus. And Staph aureus is a bacteria that lives on the skin and mucous membranes of about 1 in 5 healthy adults. And it typically doesn't cause any signs or lead to disease, but it is capable of causing severe infections. So MRSA is Staphylococcus aureus that has developed resistance to antibiotics, and it's most commonly spread via the transiently colonized hands of healthcare workers. So we have a case scenario that we'd like to chat about. So it's MRSA in long-term care homes. And if you can imagine that one of your residents has been in the hospital, say for a couple of weeks, and has just transferred back to their room. The discharge summary from the hospital indicates that the resident's admission swab to that hospital came back positive for MRSA. The resident had been in a shared room with a single roommate for several years at the long-term care home, and they didn't know that they had been colonized with MRSA, no prior history, and the resident remains asymptomatic. So the poll question is, what will be your first step in managing MRSA in the long-term care setting? Attendees will give a minute or so to answer this question. The different options we have are initiate contact precautions for the resident with MRSA, swab the roommate for MRSA, or transfer the resident to hospital for MRSA management. Okay, thanks, capacity building. So we have about 90% chose option 1, so initiate contact precautions for the resident, and this is the correct answer. So if you remember, the question was, what would the very first step be in managing this patient? And so implementing contact precautions for that resident will ensure that staff who are providing care are wearing the correct PPE to help limit spread in the home, and also lessen the risk for their roommate. Just for the other 2 options to discuss them. So initiating contact precautions, like we said, would be the first step. We would also need to swab the resident's roommate to see if they also have MRSA, but importantly, we would want to initiate the resident with MRSA on contact precautions first. And then for the third option, the resident does not need to be transferred to the hospital for management of the MRSA. They're not experiencing any signs of infection, so it doesn't need to be treated. And then this would also be similar for the roommate. So we would need to swab the roommate. If it came back positive, we would implement contact precautions for that resident also. But again, we wouldn't need to send them to hospital for treatment unless they are experiencing signs of infection. And then capacity building, if we could pull up the second poll. Okay, so the second poll question is, how would you accommodate this resident with MRSA in a long-term care home? And the options are to move the resident to a single room, move the roommate to a different room, provide the resident with their own toileting facilities, or prohibit the resident from participating in group activities, such as communal dining in the dining room. And we'll give you just a few seconds again to answer this. Okay, thank you for voting in this poll, everyone. So the correct answer is actually number 3. So the home would like to dedicate toileting facilities to the resident who is positive with MRSA. So if we are unable to dedicate a washroom to the resident, they or their roommate can be provided a commode so that they don't need to be sharing the washroom. So what we can do, what is probably the safest, is to provide the roommate who is not colonized with an ARO the commode, so that we're lessening the risk of cross-contamination in the washroom. Because if we're having the roommate who doesn't have MRSA use the toilet, the resident with MRSA, their waste may be disposed of in the washroom, which could put their roommate at risk. For the other options, for the other options, for option number 1, it is incorrect to move the resident to a single room. So we know it would be ideal to have everybody with an ARO in private rooms to limit transmission in the home, but long-term care homes are considered a home environment. And so we try to limit disruption to the residents' lives as much as possible. The second option also we didn't consider correct because the resident who returned with MRSA was positive on admission to the hospital, the roommate's already been exposed. Like we mentioned on the previous slide, we would need to screen them for MRSA, and if they tested positive, we would implement contact precautions for them also, but we don't need to move them to a single room at this time. And then the final option, option 4, is also incorrect. So as I mentioned, this is their home setting, and we try to always encourage group activities unless there's a specific risk to other residents. So there are a few specific scenarios where residents with AROs, we would recommend that they stay confined to their room, but this is the exception rather than the rule, and we will talk about these a little bit later in the presentation. So we'll now move on to talk about VRE, or vancomycin-resistant enterococci. And so VRE are enterococci, they're common bacteria that live in the gastrointestinal tract of most people, and it can be found in or on other body sites. And these enterococci have developed specific resistance to vancomycin, as the name suggests. And most individuals who are colonized with VRE don't show signs or symptoms of infection, but they are able to cause serious infections. And then for the ESBL, so ESBL stands for extended spectrum beta-lactamase, which is an enzyme that is produced by bacteria that can break down commonly used antibiotics. ESBL producing bacteria most often colonize the lower GI tract, and common ESBL producing bacteria include E. coli and Klebsiella pneumoniae. Not all settings perform routine screening for ESBL, and the decision about whether your setting should implement an ESBL surveillance program is determined based on local epidemiology. And so if the prevalence of ESBL is high in your community, and this would be based on local public health data, there is some value in routine screening, and this can be discussed at your IPAC committee meetings. So moving on from the ESBL producing organisms, we'll chat about CPE, or Carbapenemase-producing Enterobacteriaceae, which is a bit of a newer organism. So we have a little bit more information on this for you. We'll start with some definitions to help understand what CPE are. So Carbapenemase-producing Enterobacteriaceae is the name, and Enterobacteriaceae are a family of gram-negative bacteria, again found in the gastrointestinal tract, and include common gram-negative rods such as E. coli and Klebsiella species. Carbapenems are a class of antibiotics. They're among the strongest antibiotics that we have available, and so they're used to treat infections that are already difficult to treat. And carbapenem antibiotics that you might have heard of include meropenem and ertapenem. And so bacteria can have many mechanisms by which they are resistant to antibiotics, but the mechanism of resistance that we are specifically concerned with in healthcare is by the action of carbapenemase enzymes. And that's because the genes that code for these enzymes are found on mobile genetic elements called plasmids. And what that means, it's kind of a sciencey way of saying that this resistance is very easily transferable among bacterial species. So if you have a Citrobacter next to an E. coli, and one has the ability to produce these carbapenemase enzymes, it's really easy for it to hop from one bacteria to the other. Some of the examples of the carbapenemase enzymes that we see frequently in Ontario include NDM1, KPC, and OXA48. And so putting this all together, CPE are Enterobacteriaceae that have acquired transmissible resistance to the carbapenems. And again, it just means it's able to easily hop from one species to the other. Okay, so we know what CPE is. Why are we concerned about it? So serious infections are associated with a greater than 50% mortality rate. So CPE is a significant clinical and public health concern. It has the ability to spread rapidly in healthcare settings. The main reservoir of CPE is colonized patients and residents, but environmental contamination, especially drains, so sink and shower drains, have been implicated in transmission. So CPE can result in prolonged colonization, and about 16.5% of individuals who are colonized with CPE go on to develop infections. And then in almost all instances of CPE, they're resistant not only to the carbapenems, but also first, second, and third generation cephalosporins, as well as penicillins. And because of this extensive resistance, there's almost no antibiotic treatment options available for these infections. And the antibiotics that are available are often associated with toxic side effects. So we'll have another scenario now. Imagine, so and it's CPE in an acute care setting. So imagine that we have a 68-year-old dialysis patient who's been admitted to the hospital with high fever, chills, and confusion. They've had recent hospitalizations for a complicated UTI and have had several courses of antibiotics. The physical examination reveals signs of sepsis, including rapid heart rate and low blood pressure. They've identified no localized signs of infection, and blood cultures have returned positive for CPE. So in this poll, we're hoping you can choose all of the correct answers. The question is, what infection prevention and control measures should be implemented for a CPE positive patient? And capacity building, thank you. So the options are, and again, it's choose all that apply. Initiate contact precautions for the patient. place the patient in a private room, cohort with other CPE positive patients, and dedicate equipment as possible, or ensure adequate cleaning and disinfection between patient use. Okay, thank you everyone for populating with your responses. So this is a little bit of a tricky question. So the correct answers we were looking for are 1, 2, and 4. So initiate contact precautions, move the patient to a private room, and dedicate supplies as able, ensuring adequate cleaning and disinfection when unable. So per option 2, right, ideally we would place the patient in a private room. If it isn't possible, that's when we would consider cohorting with other CPE positive patients. So number 3 could be an appropriate response if there are no private rooms available, but the priority should be to have the patient in a private room before cohorting with other positive patients. And then again, for option 4, ideally we would dedicate supplies and equipment, but if this is not possible, just to ensure adequate cleaning and disinfection of shared equipment. And so finally, the last ARO that we'll chat about today is the newest. And so this may be new information again for some of you. We don't see this organism very often, but it's Candida auris, or C. auris. So C. auris is an emerging fungal pathogen that can be highly resistant to the antifungal agents that are normally used to treat Candida species. It was first discovered in Japan in 2009. And between 2012 and 2023, Canada has seen 43 cases of C. auris. 19 of those 43 were just identified in the last 3 years. And of those 19 cases identified in the last 3 years, 15 of these have been in Ontario. So Ontario has seen 21 cases in total through to 2024. But again, almost more than half of these have been seen just in the last few years. Candida auris has been reported in at least 50 countries on 6 continents, and the US has reported more than 5,600 cases in the last 10 years. So while we may not see a lot of cases in Ontario, there are a lot of cases close to home. Michigan has had really bad outbreaks of this. New York State has had awful outbreaks of it. So we will be seeing this organism more and more. Common sites for colonization of C. auris include the skin, so especially the groin and axilla, mucosal surfaces of the gastrointestinal and genitourinary tracts, the respiratory tract, as well as the ear. And so that's some background about Candida auris. So why are we concerned? As mentioned, it is highly resistant to it can be highly resistant to the antifungal agents that are normally used to treat Candida species. And most of the C. auris isolates that we see are resistant to at least one class of antifungals. In the United States, South America, and India, they report that 4% of their isolates are pan-resistant, meaning there are no antifungal drugs left to treat these infections. C. auris is capable of causing severe invasive disease, particularly in those who are critically ill, and nearly 10% of individuals who are colonized with C. auris will develop infections, and it's most often in those who are critically ill, so ventilated in the ICU. And the mortality rate for these infections sits just under 40%. I think it's 39%. C. auris is also a cause of extensive outbreaks in hospitals. It can persist on surfaces for very long times, so at least 14 days on inanimate objects. It's been shown to survive 7 days in bedding. And Candida auris is also quite resistant to common cleaning and disinfecting agents that we see in healthcare facilities. So outbreaks that have happened result in long-term endemic colonization and infections in the affected facilities and dissemination of the multi-drug resistant organism to other facilities. And we've seen regional and countrywide spread in the United States, specifically within healthcare organizations. And so finally, as if all of this wasn't worrying enough, this organism is also quite difficult to identify in the lab. And so I hope you found this sort of background booster helpful, and I will pass this over to my colleague Eva, who will chat with you about how to manage AROs and which resources PHO has available to help support you in this. Thank you.
Thank you so much, Catherine. So now that we have a better knowledge and understanding of the different types of AROs, we will move on to preventative measures and some IPAC practices, of course, with reference to the numerous resources at PHO. So screening would be the first and most important step of early identification of colonization or infection of AROs. So a questionnaire should be completed for all patients, residents who are admitted to the facility in order to determine who is at risk for being colonized for AROs. So we would look at prior history of colonization or infection with AROs, healthcare facility exposure, so admission or spend more than 12 hours in the past 12 months, also transfer between healthcare facilities or exposure to an outbreak or exposure to a known case of ARO, as well as high-risk medical conditions like comorbidities. And risk factors may also be identified during admission. So, for example, a roommate of a case. And many long-term care homes actually practice universal screening on admission, which means screening all the residents that are being admitted to the facility. Because when you look at the resident population, many will have comorbidities or high-risk medical conditions and a recent exposure to healthcare facility, as they are often not admitted from a hospital. So specimens should be collected for testing from those who are at risk as per risk factors, and the sites that would be swabbed. So for MRSA, it would be nares, perineal, skin, wounds. For VRE, CPE, and ESBL, stool is preferred, or a rectal swab, because those organisms live in the rectum or lower intestines. And C. auris would be combined bilateral axilla and groin, as well as nares. And also a point prevalence may be indicated during an outbreak, and point prevalence screen is the collection of specimens on all patients, residents, or clients at a single point in time in order to determine the total number of cases and evidence of ongoing transmission of a particular microorganism. So point prevalence screens should be conducted on either units or areas where the patient or resident are at high risk for acquiring AROs during their stay in the healthcare setting. And then patients and residents at high risk include those, for example, in burn units or ICUs or transplant units. And the point prevalence screens should be conducted and should continue to be conducted until no further transmission is detected. In general, this means at least 2 prevalence screens taken after the last transmission was detected and at least a week apart. And PHO has recently published an updated screening tool for AROs. So the risk factor-based screening identifies patients, residents, or clients at increased risk of having AROs. And the goal of the screening is to identify all patients, residents, or clients who are colonized or infected with AROs as early as possible. And this is to implement infection prevention control measures to reduce the risk of transmission to others. And this tool was designed to support healthcare professionals in screening and managing all AROs in all healthcare settings, and it can be used at point of care. So AROs are most commonly spread on the hands of healthcare workers. So healthcare workers may pick it up from contact with patient, resident, and client who has an ARO, or after touching contaminated surfaces, material, or equipment. And as we know, AROs can live on hands and objects in the environment. Therefore, hand hygiene and environmental cleaning are the most important measures to prevent the spread of AROs. So what are the IPAC measures that should be implemented to prevent the transmission? Routine practices, of course, are always in place when caring for patients, residents, or client, and will be discussed on the next slide. So patient, resident, and client who have MRSA, VRE, ESBL, CP, or auris will be placed on additional precautions or contact precautions. And this often means private room with dedicated toileting, as Catherine mentioned earlier. So there's a slight difference. In acute care facility, contact precautions mean that anyone who enters the room should wear a long sleeve gown and gloves, and this is in order to prevent skin and clothing from picking up AROs. And in long-term care homes or retirement homes, gown and gloves are to be worn for direct care or if contact with resident or their environment is anticipated. So question regarding mobility often comes up. So are these patients or residents allowed to leave the room? So in acute care facility, prior to patients leaving the room, you would need to do a risk assessment if there is any risk of transmission, and that would be done on case-by-case basis. And in long-term care homes or retirement homes, as Catherine has mentioned, individuals with AROs should not be required to stay in the room unless they're, for example, unable to comply with the hygienic measures, or they have uncontained draining wounds or feces, and also uncontained cough, and that's for MRSA. So back to routine practices. Routine practices refer to a minimum IPAC practices that should be used with all patients, residents, and clients during all care. And this is in order to prevent and control transmission of microorganisms or organisms in all healthcare settings. And it is so the first most important step is the risk assessment. And this is done prior to every interaction between a healthcare worker and a patient, resident, client. Also, as I mentioned earlier, hand hygiene, following the 4 moments of hand hygiene, as well as environmental controls. So meticulous cleaning of the healthcare environment, cleaning of the surfaces, equipment, and also administrative control, so making sure that the policies and procedures are up to date and readily available for staff reference, staff education, huddles, education of your patients and residents, family members, visitors, as well as audits. So for example, auditing hand hygiene practices, PPEs, putting on and taking off. Those are some of the examples. And lastly, personal protective equipment, making sure that there is a sufficient supply, easily available and accessible in different sizes, especially when it comes to gloves. So back to hand hygiene, as I mentioned, it is one of the most effective measures to prevent the spread of infections. And alcohol-based hand rub is the preferred method when the hands are not visibly soiled, or a dedicated hand washing sink to clean hands with soap and water when hands are visibly soiled. And as we know, the viable microorganisms, or the AROs, can persist on surfaces and items for prolonged periods of time, even months, particularly organisms such as VRE or MRSA. Hence the reason environmental cleaning is so important. So there's slight differences. So for MRSA and ESBL, daily routine cleaning and disinfection with health care grade disinfectant is sufficient, and routine cleaning and disinfection should be done on discharge, transfer, or removal of contact precautions. For VRE, CPE, and auris, those have a bit of a unique cleaning recommendations and considerations. So specifically for VRE, because it can persist on prolonged periods of time in the healthcare environment, And routine cleaning and disinfection often fails to remove VRE from surfaces. Therefore, twice daily routine cleaning of rooms may be considered, and rooms should be cleaned twice daily during an outbreak of VRE or at facilities with ongoing uncontrolled VRE transmission. And then for CPE, rooms receive daily routine cleaning and disinfection, but you need to pay particular attention to sink cleaning and disinfection, as CPE can form biofilms in sink drains that are sometimes challenging to remove. And also facilities might consider routine enhanced cleaning of sinks and showers, for example, twice weekly or on discharge or transfer cleaning. And for auris, again, routine cleaning. However, you might consider twice daily cleaning and disinfection, and sodium hypochlorite or bleach and improved hydrogen peroxide is the preferred method to kill auris, and quaternary ammonium compounds or quads should not be used for disinfection of their environment or equipment. And in terms of laundry, for all of AROs, routine practices for handling and laundering are sufficient, regardless of the source of the linen, and special handling of linen for patients, residents, clients, and additional precautions is not routinely required, and just a regular waste or garbage disposal. So in terms of additional precautions, patients, residents, or clients who have AROs are often placed in private rooms with own toileting facilities. And as we mentioned earlier, in acute care, anyone who enters the room should wear a long sleeve gown and gloves. And in long-term care facility, gowns and gloves are required for direct care. And of course, single rooms might be limited, so priority should be given to patients, residents who are at increased risk of spreading the organism. So, for example, if they have draining wounds or they are incontinent. And single room is ideal, but not always workable. So placing with the same infection or colonization would be another choice, or placing with low risk patient, resident, who doesn't have any indwelling urinary catheters or open wounds. And of course, signage should be available as a communication tool. And you will also be able to find sample contact precaution signs on PHO website. Ideally, any equipment used should be dedicated. However, that is not always feasible. Therefore, shared equipment should be cleaned and disinfected as per routine practices, and additional environmental cleaning practices might be implemented as I described in the previous slide. So how can we improve adherence to contact precautions? So this is just a nice summary. So ensuring staff receive comprehensive training on ARO transmission, emphasizing the importance of hand hygiene and proper use of contact precautions, providing clear and accessible education to patients, residents, clients, their families, and visitors about ARO transmission, and also importance of contact precautions, and having some written material as well as verbal instructions and demonstration to reinforce IPAC best practices. So as we mentioned, there's a number of resources that do support ARO best practices. And for your convenience and easy access, we have included links to ARO related resources, and you might also want to visit PHO website and access these resources through healthcare associated infections tab. And there is many ways actually how you can access these resources. Another example would be searching for specific organisms, and then you will find landing pages for MRSA, VRE, CPE, and auris. And in terms of the links to the resources, we kind of divided them into foundational resources and and practical resources. So here's you can see a list of foundational resources for MRSA, VRE, CPE, and ESBL. And as Catherine mentioned, the presentation will be available on our website, so you can easily access these resources. So I separated the foundational resources for MRSA, VRE, CPE, and ESBL, and foundational resources for C. auris. So there's two resources listed here. The interim guide for infection prevention control of Candida auris that was released in January 2019. And this document provides interim recommendations for healthcare facilities and microbiology laboratories for identifying and caring for patients and residents with Candida auris colonization or infection. And the second resource is PHO focus on Candida auris, released in June 2023. And this is a summary of the epidemiology, mode of spread, resistance profile, disease severity, diagnostics and surveillance of C. auris, and also control measures to reduce or prevent its spread. And we've also included a direct link to the Candida auris dedicated webpage. On this slide, you will see some additional practical tools that are related to MRSA, VRE, CPE, and ESBL. I'm not going to go through all of them in the interest of time. And then practical tools, so specific ones to the CPE, and then some practical tools specific to C. auris. So in summary, some of the key highlights, controlling the spread of AROs in healthcare setting is essential. And you can identify patients, residents, and clients at risk for colonization or infection using the ARO screening tool to look for some of the risk factors on admission or readmission. And when you identify AROs early on, you can then reduce the negative impacts on patients, residents, and clients' outcomes, and then reduce healthcare costs. So please do check out the resources discussed in this presentation. Those can help you to support you in identifying and safely managing patient, residents, and clients with AROs. We have also provided reference slides. And for more information about this presentation, or if you have any IPAC related questions, please do contact us at IPAC, IPAC at oahpp.ca. And thank you so much. And over to you, Laurie.
That was an amazing presentation. Thank you so much, Eva and Catherine. It was really insightful and lots of good information and great links. We're going to move to the Q&A portion of our webinar. So I encourage you, if you haven't already done so, to pop your questions in the Q&A pod at the bottom of your screen. And we also have a couple of links in the chat. The one I want to highlight for you, because there were a lot of questions that came in regarding what questions to screen for and also what follow-up actions in terms of testing for AROs. And it's the ARO risk factor screening guide, and it's a great guide to go through. It's new and on our website, and includes updated information that Eva and Catherine have gone through. So I'm going to start with one question that's really common. We get it asked a lot, and many of you in some shape or form have asked this question in the chat. Are there criteria for discontinuing contact precautions, or do these patients, residents, clients need contact precautions forever? So I know some questions came in specific to MRSA, VRE, and ESBL. There were some questions on CPE, and also people may have questions about C. auris. So I'm wondering if you can, either of you can speak to what do we do with people and leaving them on contact precautions, or where would we find this information?
Thanks, Lori. Yeah, I can try and answer this question. So PIDAC Annex A, which is linked in the resources that we've provided, it's screening and management of antibiotic-resistant organisms. I forget the exact title, but it does have criteria listed in there for how you can discontinue precautions for MRSA, VRE, and ESBL. You wait a period of time and then swab them once a week for a few weeks and ensure that they're negative. For C. auris and CPE, they're newer. So PHO doesn't have specific guidance. We don't know how long people remain colonized for. And so in those situations, you should chat about it with an expert or an infectious disease physician if you have one, and see sort of how long you should wait after someone is tested positive to begin checking them for clearance. There are criteria. And IPAC Canada has put out a position statement on CPE that does include some criteria that you can use to discontinue. For C. auris, there aren't yet. I imagine they would probably stay on precautions duration of while they're admitted, but we do have criteria and they don't need to stay on precautions forever, which is the good news. And in PIDAC Annex A for MRSA, VRE, and ESBL.
Wonderful, Catherine. Anything to add, Eva?
Also, those would be a good discussion during your IPAC meetings in your facility, and maybe discussion with your local public health units as well.
Right. And possibly we could pop the link into the chat for the PIDAC Annex A, so you have that, as well as the position statement for IPAC Canada. We can share that as well. Thank you both. One other, well, quite a few questions came up in the Q&A on contact precautions for AROs and when to apply them in various circumstances. I'm wondering if we can just pull up, we have a nice poster of and this came up also because we get many questions about hand hygiene, putting on and taking off PPE, and people missing hand hygiene as well when people are on contact precautions. So I kind of want to combine what are contact precautions, when would you apply them, and then the sequencing of hand hygiene and PPE. And I know we have a nice PHO infographic on that. So I'm just wondering if we can pull that up. And just ask both of you if you have any suggestions on how to support facilities in promoting these best practices for PPE and hand hygiene when we're using contact precautions.
Yes, so I find that visual resources are always appreciated. So that one pager that Lori is referring to on the sequence of putting on and then removing personal protective equipment, as well as I mentioned earlier, we do have signage for contact precautions specific to acute care and also specific to long-term care. So those could be used as well. And lots of, I guess, short one-on-one kind of huddles on the units, 10 minutes of orientating staff to the resources that are available, maybe doing audits, maybe presentations of how to put on and remove PPEs for patients or residents and their visitors. Again, those visual resources could be utilized. I know in long-term care homes quite often infection control practitioners or specialists will do short presentations at the family or resident council. Those are kind of nice venues to utilize opportunities to educate both residents, families, patients, and staff.
Thank you. Okay, we had a question that came in about a resident that has 3 different AROs and also a catheter, and continually has bacteria that causes symptoms, and the doctor tries to treat. So I'm not sure if this is in scope with what we're talking about, but it's mentioned that after antibiotic treatments, the resident is still positive for bacteria, I'm assuming in the urine, and it hasn't gone away for over months and months. Is there anything we can do? Did either of you want to address that?
Sure, I can. So at PHO, we have a really wonderful UTI for long-term care facilities program. It is for a non-catheterized residents. So I would encourage long-term care facilities to familiarize themselves with the program. But specifically to answer this question, it is not really recommended to test for cure after course of antibiotic or treatment, because the bioburden might still be there, and the test might still become positive. And really assessing the resident for signs and symptoms of infection. It seems like this resident could potentially be still colonized, but maybe not infected. So really looking at the clinical presentation and signs and symptoms of UTI. However, if this continues to be a challenge, perhaps suggesting to the physician to do a referral for IPAC specialist. Thank you.
Great.
Catherine, anything to add?
Sort of a little bit along different lines, but I see some questions sort of the same in the chat. Just I'm not sure if they were wondering if they should test to see if they've cleared it, right? So you should wait a period of time after they've had antibiotics that could affect the growth of those organisms, but you can test them. I mean, if they're testing positive for a year, you probably aren't going to screen them once a month to see if they've cleaned it, but you could swab them every 3 months, every 6 months, because some people will clear it on their own, but not everyone. So that's the same for all of the AROs. As you know, if someone is persistently positive, you can wait some time and then rescreen them, as some people will clear it, but some will remain colonized forever also. So just have to test. Sorry, thank you.
Very common question. Thank you both. We have about not even a minute left here for one more question, and I apologize we couldn't get through all of them, but hopefully we answered many of them for you. And this one is just, is there one swab that fits all to catch all AROs? We currently only swab for MRSA, but I think we should be swabbing for all of them. And I think we could probably refer again, maybe if we want to put that link back in the bottom of the chat for our screening tool again.
Yeah, the ARO screening tool indicates the different sites. There isn't one swab that can be used in the lab for all of the different sites. I think they've combined MRSA and VRE together depending on the lab you use, but yeah, there isn't sadly just one swab, and different sites, even for one organism, may require multiple swabs.
Great, thank you so much. Well, we thank everyone for attending today. There were a lot of great questions, and as we conclude National Infection Control Week and today's PHO webinar, I'd like to thank both Catherine Kerr and Eva Skiba for their excellent presentation. I'd also like to thank Casey Gambetta for co-moderating with me, and of course, a special thank you to everyone who joined us today for today's PHO session. You can expect to receive a brief and anonymous survey for today's session. Please try to complete this to help us improve our programming. Lastly, to access today's PHO presentation, review past presentations and recordings, and view upcoming presentations, please visit the PHO website, navigate to Education and Events, and click on Presentations. So thank you and have a wonderful day.